Hi, Vinita.
Hi, and I was just wondering, it was supposed to be a panel. It's got converted last minute, I think, to fireside chat, just the two of us.
Which is great because you were saying we should meet afterwards for 10 minutes. We'll just have our conversation while we're here. But thank you so much, NASCOM, for inviting us. Thank you, all of you, for joining into this interesting conversation. And thank you, Vinita, because, we've got, between the two of us, we have public and private healthcare on the stage. So it'll be a fun conversation.
And truly fire, unlike the last one.
Absolutely, totally.
Yeah.
We'll also, at the end of it, keep some time in case anybody may have some questions or clarifications that you'd like to look at. But what's happened during COVID is health has come front and center. Interestingly, I think one of the things that happened for us at PATH and in the public health system was the realization that equity was critical. COVID didn't spare anyone. It had, it went across the whole economics piece. It went across social barriers, and all of us were affected, which also kind of told us the importance of health equity, the importance that we really need to work together to make sure health is equitable and services are available to all. And I know that you as an individual and Apollo did a lot of work in that space. So, just tell me, coming out of COVID, and I don't know, some of us believe we haven't come out yet, but I think we're out of it. What are your emotions as in terms of technology and how that helped us in the time of need?
So let me say these are not prepared questions at all. Neeraj is catching me, and I hope he won't catch me on the wrong foot. To just step back, honestly speaking, maybe not COVID, but if you guys have been clued on to the World Economic Forum, and I'm a deputy lead for health there, we're talking of a disease X. So it need not be COVID, but the danger of and the time bomb on which we are sitting of infectious diseases is going to be there for a long, long time. To answer your question, how did we, to prepare and how did we really think technology helped us? I think it was a game-changing moment for healthcare. Everything that we were trying to do for 20 years got time warped in 6 months. Not just what private and public sector were trying to do through telemedicine, through digital tools, but the entire regulatory landscape. I come from public affairs. My work is, should I go slower? My work is a lot in public policy. And before joining healthcare, I was in telecom and I was with Bharti Airtel. And so I have seen how this intersection between telecom and healthcare was rapidly absorbed by all three stakeholders, the providers, the government in giving us that regulatory landscape, and the consumers. So I think COVID smashed the metrics of brick and mortar. People no longer thought it was essential to witness, to actually go to, and they couldn't go. We were triaging patients for OPDs. Everything was happening on teleconsults. In 6 months, we were seeing millions of people connecting with us. The issue that we faced, which you correctly mentioned, was how do we sustain this in a judicious, equitous manner? Because that was a time of an emergency response. Now is an opportunity to unlock the digital transformation with trust.
Absolutely. And Vinita, going back to the whole immunization program, the vaccination, I have to tell you this story. I had an American friend and we traveled to Ladakh in the middle of, I think it was the second and the third wave. And we landed and the lady at the security person said, "Can I see your COVID vaccination certificate?" And I pulled out my phone and I said, "Yeah, here it is." She said, "Yeah, go for it." And my American friend pulled out his wallet and he started opening this little piece of paper, which was supposedly his vaccination certificate. And she said, no, this is not what I want. I want your vaccination certificate. I mean, just imagine if we were trying to do 1.1 billion people with paper pieces, that would have been a bit crazy.
Can I add to what you're saying? So at that time, if you realize, there were so many restrictions and, global movement was becoming so difficult. And I got pulled into a meeting with IATA. It was a moment of so much gratification that when they asked us, how are your systems preparing in case the global passports are replaced by COVID passports? I said, we are there. All data of vaccination and everything between government portals and private sector hospital portals were all there. To be honest, in October 6 months before we actually started the COVID preparation in the country, we had launched something called an Apollo 24/7, which was AI backed. We were already prepared with an infectious disease platform. So we had invested in it. And we could quickly roll out what the government later on called on how, you can assess risk assessment for COVID. So I think what the biggest lesson was, whether it was mRNA vaccines or anything else, you have to stay invested. The fact that today there's a 100-day mission in which you can produce mRNA vaccines is only because in the past we were able to invest in it, so we could pick out those molecules and immediately move them into whether recalibrate for drugs or recalibrate for vaccines. And that is the key to equity.
And that's going to be the future. I mean, tech is going to, when we think of tech, we get limited to probably telehealth. But actually, tech is running across from development of products. A vaccine development typically used to take 10 years. And because of the use of technology, digital, we are able to accelerate that. The whole process of regulatory has changed because of the use of technology.
Neeraj, I want to ask you here something. The whole landscape of regulatory has changed. Tell me, you work in public and that intersection with the private and the policy landscape. How are you working differently, say from a private sector perspective, or there are intersection points where we can work together?
I think what we saw in COVID was public and private came together. Okay, there's no question on that, because that whole feeling of mistrust that we have, not us, but public and private, that kind of vanished. And I think it's important for us to accept that for sustainability, for equity across the board, we will have to work together. So public and private will have to come together. I mean, the National Digital Health Mission is a great example. I'm not sure if people in the audience are aware, but the National Digital Health Mission that has been rolled out brings together public, private, labs, everything on one platform, which means we will have data coming in to be able to prepare for the next pandemic from both public and private. We will also look at when we think of, I remember, when we thought of laboratories for diagnostic, initially the government was only thinking of public health laboratories. And then we said, no, this is not just a public health thing, it's everybody. So how does that all come together? How does that data start flowing? But more importantly, we are 1.4 billion people. Primary healthcare. And how are we going to use technology for screening, for diagnostic? And how are we going to partner, I think, is going to be critical.
So I have the stats with me. My team was very nervous about this meeting, saying that, Neeraj is going to be there. So they gave me a data statistics. I don't know how many of you know, what is really the biggest challenge we are facing in healthcare. And that's where I find technology is going to be a key enabler. It is not about the number of hospitals, it's about the number of people, the workforce. And today, in primary healthcare centers, since you mentioned, we have about 33 to 55% shortage, as per the FICCI recent report that they had launched. We have 1.4 beds only per 1,000 population. Nurses, we have one nurse for 670 people. Doctors, we have one doctor for 10 or 11,000 people. This is a huge deficiency. And I can only, Neeraj, think of one very key enabler here, which is technology. But having said that, I remember Bill Gates' very famous statement that automation, if it is put on a system which works efficiently, will amplify efficiency. If automation is put on a system which does not work efficiently, will amplify inefficiency. So it's not to say that healthcare is all great. We have so many issues. So, this is where we need the guardrails, all stakeholders to come together with technology.
Totally, Vinita. And a lot of people have been talking. Have you heard the term digital health? Can I see some hands here? This was more to check if you're still listening, okay? So digital health, there is no digital health. It's health. And digital is just a means to get there. So if you're going to force digital in, it's probably not going to work. But just coming back to your data sets, the other challenge is that 75% of our healthcare infrastructure and providers, which Vinita just talked about, is in the urban areas. Whereas our population, only 27% is in the urban areas. So there's a huge
Not just
imbalance.
rural, urban. I mean, look at the biases. So that's a big concern. How are we going to really have the feedback loops when we use machine learning, AI in healthcare, which builds on algorithms, which are all based on those huge reservoirs of data sets, which may have a lot of biases that go against inclusion, gender. So, women, and especially since I see a lot of women in this room, you'll be really disturbed when I tell you this. We're not even a part of the research studies. We are using the same drugs that are given to men. We are using the same replacement for hips and knees that are actually built for men's anatomy. Women have been left out from research for many, many years. And this is a bias which has got built into all the data. So the first thing is to basically use that another layer of correcting that data for data analytics. So I think we have to start, we can all capture data out there, whether it's eSanjeevani, whether it's telehealth, whether it's public or private sector electronic medical records. And that's the other thing, to make them interoperable and share them, right? But more important is how do we really include class, gender, ethnicity, have disaggregated data to be able to really provide what you call human centricity in healthcare delivery.
Well, I mean, absolutely. And I'm happy to say that the government is now recognizing the importance. Having said that, I mean, we are still at gender. We haven't gone beyond that yet. But, I think you're absolutely right that we will have to go beyond that. Okay. Vinita, you had a set of questions that I'd sent you, which we haven't even got to. So maybe we'll get there a little bit. I'm going to ask you very specifically intersectoral collaboration. We talked a little bit about it and partnerships. And I know that Apollo does a lot of work, and I've come in touch with many of your activities there. I know that equity and inclusion is an important part, but so is making money. You have to be sustainable, which means eventually you need to make money. So how are we going to get to universal health coverage while keeping all these agendas in mind and making sure we are actually playing to all these agendas that different individuals or organizations or functions have? How are we going to get there? Any thoughts on that?
So I'll tell you of some wonderful initiatives. You're very right, to give access and affordability is very important. But always remember, health is a public good, right? It's the responsibility of the governments. It's the responsibility of everybody to join hands. Now, I'm again going to leverage my answer on technology because that's why we are here. I was a part of this wonderful initiative called Edison Alliance in the World Economic Forum. It got launched the report day before. This was launched in the middle of COVID 3 years ago. And again, all the healthcare providers, forget Apollo, it had the biggest names you want, Mayo, so Sloan Kettering, it had Jefferson, it had the EU commissions, it had all the tech companies in it. And we were asking the same question that now with COVID, the health inequity, the gaps and the cracks in how we were giving healthcare have come forward. And this can't be sustained the way we have been, catering to, say, whatever percentage of population. And the next thing that faced us was not healthcare inequity alone, the tech inequity. And since we are at NASSCOM, and they have better stats than I do here, the entire access to internet, the broadband, you can give them smartphones for vaccine nudges in the villages, but how many are really digitally literate to handle those smartphones? And how are you really looking at the digital gap? So what the Alliance did, and I'm coming straight to a solution here, on how we can approach this inequity, we decided to marry tech and healthcare delivery. And marry it in such a way that we should make a sustainable business case. That's where business is not a bad thing. Because only when you have a sustainable business case will you attract investors. And to make it long-term, the government will need to come with a policy framework which includes incentives, which also includes a lot of reimbursements. To tell you honestly, I wasn't sure because I was one of the deputy leads of healthcare. If we were looking at 1 billion lives globally to touch in health, education, and financial inclusion, I thought, my God, this is too huge a staying target, and they made me the deputy lead of the health committee. Ajay Banga was then from MasterCard leading it, right? And Ajay said, and we also want to move the gender needle here. I'm like, God, I don't know if we can touch this. But yesterday's report, 6 months before the target, we've almost hit 790 million people. So 1 billion in 2 months. We're going to do this. So how did this happen? It happened because we were able to get all the corporates and run lighthouse projects, even in Africa. I'm not talking of India, in Sri Lanka, in Rwanda, where tech was the main pillar around which the telehealth models, the digital health models started getting created. In India, it was in Madhya Pradesh that we had 200 villages covered by digital dispensaries. So what we did, we got a American company. They're exiting India, so I can't name them. But they put the whole CSR funds in our hands here and said, okay, run the digital dispensaries. Because no single entity can run this alone. We have covered 200,000 people with telehealth consultations. You know what we saw with the 5 digital dispensaries? It was the women who started hitting the digital dispensaries more. And once a woman in a family gets connected with healthcare, the whole family gets connected. So we got our numbers, right? It's a great model. And this is the 3rd year. So what I'm trying to say is, alongside what we did, we built a navigation tool for policy changes we needed. So like telemedicine guidelines, right? We told them how these can be more attuned. Again, questions of, we haven't yet, this whole model is actually based on AI and machine learnings, because, it's not that all the time people come to the centers. We also have people like ASHA workers, who go to their homes to nudge them. And they have been given tablets. So they're able to put the records directly into the system without, human error. So the policy had to cover a lot of reskilling. That is an area where I feel we still have a lot more to do. How do we upskill our healthcare workforce in these new tools? So whether it's a private sector or a public sector provider, I think the moment you make a sustainable case, which is a kind of a business case, then you are able to replow the revenues, the money into these kind of projects.
And this example you gave, is there a wave that can be scaled up across?
Absolutely, it's a playbook today. It has all the pivots that you can use. So we are using it as a playbook. For your reference, you can look at the World Economic Forum, Edison Alliance site. It's all there. The impact stories are there. Includes impact stories like in Bangladesh, even in Pakistan, where people are creating these kind of tools. So it can be replicated anywhere. What you need is the right intent and people ready to put that fund for the cause. So a common shared goal is what made us move.
Fantastic. I'm going to move a little bit onto primary health and screening and diagnostic. We're a large country with a lot of people, 1.4 billion going. The challenge that we are finding, especially in public health, especially in low resource settings, is how do you actually screen early for early intervention so that people are healthy. So actually moving towards the whole wellness theory of finding the challenge early and starting to deal with it. Now, the way we are spread out as a country, the way our populations are spread out, the fact that there is cost-wise, there are issues of being able to pay for services. One of the things that we've identified in the public health space is how do we use technology to screen large populations on the ground in primary care settings, in homes, for cancers, for NCDs, across the board. Recently, we've been doing a lot of work on mental health around that, and even the infectious diseases. Do we have rapid tests which could do it? TB is one where we are doing a lot of work already on. We've got AI-based stethoscopes. So you're kind of ensuring that you are able to screen people who are not symptomatic.
So it is so important, and thanks for mentioning this, because I also work with FIND and in tuberculosis. So we're actually doing projects for ending workplace TB, for instance, for ending TB in remote areas, because the biggest challenge is it goes undiagnosed. And today, through exactly what you said, the ready to wear and the point of care devices, we are using methodologies where, so for example, you just go to check somebody for chronic cough and you realize the person has tuberculosis. And that's by the kind of cough. You can record it with an AI algorithm and you're able to figure it out from a village to, our nerve centers, that this is what's happening. Same thing with cancer. So like QI Cure and all, they've created these very easy, ready-to-use, hand-used cancer screening equipments which can help in detecting cancer. So we're working in all these areas. The only issue is, I think we still are very fragmented. And there's no standardization. And because, we need to create those standards when we work. My fear sometimes is the fly-by-night operators, and that's a very big concern. So we need some kind of a policy towards use of AI, use of machine learning in a way that, things get standardized. I'll give you an example also of teleophthalmology. In Uttar Pradesh, we're running these teleophthalmology primary healthcare centers where we use a kind of AI tool where, for example, if a patient comes, the retina is checked, and the patient is made to wait for just 5 more minutes. Why? Because we need to see the retina placement and everything is just correctly imaged properly, right? And in those 5 minutes, if the imaging is not done, we immediately call the patient back and the imaging is done, and then image is sent back to see whether the person has cataract or any other, glaucoma or anything else. This has shortened the OPD visits. This has created so much efficiency within our own system. And for the patients, they don't have to come back after 3 days for 20 km being told that no, your imaging was wrong. So, but it comes with a cost. That kind of AI needs investment. We have also seen, you must have heard, some camp was held and then all the patients became blind the next day. So you have to be very careful in technology. You have to have those guardrails.
And the whole conversation that we had at the G20 around DPIs and DPGs, and we just saw the UNDP presentation before this. We've got to go into digital public goods. They've got to be open source, digital public goods that we can access in multiple countries, roll them out, and really be able to screen at that primary level.
And today, if you see the Goldman Sachs report that came out 3-4 days back, India is right up. Because if you're transparent in your healthcare processes, I'm very proud to say Apollo has been mentioned in benchmarks where we are providing the aftercare much better than what's being provided in global hospitals. So it just depends on how much you can invest to create safe systems for patients.
Well, that's wonderful. Vinita, one of the things that you talked about a little bit was in terms of skills and people But I want you to dive a little bit deeper, especially when it comes to, primary health care facilities and the frontline workers. We all talk about the ASHAs, the ANMs, but if you go down to the ground and you meet some of these power women, they're doing such a fantastic job. How do we enable them? And most of the technology that we're taking to them actually is increasing their burden. While we believe that this is great technology and we should take it. How do we change that?
So I must say kudos to NASSCOM also. With NASSCOM, Apollo has created a lovely program where we are upskilling our workforce. We're kind of creating that threshold of digital fluency. But at the same time, what we recognize is, is that bilinguals need to be there. People who are between the coders and the actual healthcare, professionals who are able to translate that language and empower a patient, right? So when you talk of ASHA and workers, so we have a model which is an Anaconda. We call it the total health model, which is totally run on the shoulders of women who go out on the field. Some of them are, retired ASHA workers, Anganwadi workers. Exactly what you're saying, but what was needed was skilling of these. So we have programs for Apollo Med Skills and Apollo Medversity. Having said that, we have huge shortages if you talk of a national level program. During COVID vaccine time, you must have seen lots of information and videos on how the ASHA workers were traversing such tough geographical locations, crossing rivers, climbing mountains in Ladakh to get the vaccine to the right people. So that is the physical aspect. But if we have to build a workforce for tomorrow, for today, with the kind of challenges we are facing, whether it's disease X or the burgeoning NCTs, which are like and most of us are not diagnosed, we really need to skill not just the clinicians, but our front-end staff. And Neeraj, there's a great benefit in doing that. A lot of task shifting can happen. A lot of physicians will be freed of things which our frontline workers can take care of, provided they have been given those skills. Skills need a lot of things. They need funding, not just investments. They need good curated courses. They need the employers to encourage them. They need government incentives. And since you mentioned women, I have seen women who have been trained in Chennai. They refuse to come to an adjoining town to work. We need safe public spaces. We need safe, smart cities, rural areas, well connected. For a woman workforce in healthcare to go into these areas, you have to create, you have to have a very safe public transport system.
Yeah, you're absolutely right. But, it's also interesting that when we look at the gender mix in our frontline workers, it's mostly women, huh?
Yeah, that's it. And I must say kudos and imagine the economic opportunity we can unlock. And digital, again, that's why I use the word smart. You can have the smart systems like you have in the Nordic countries, where women who do late night shifts in healthcare go in these buses, which drop them at designated stations. But if it gets later, they have a connection where they just, press the bell, the driver knows, and he connects them logistically closest to a point closest to their homes.
Sure.
So
I can see a lot of
yeah.
hustle. So I just want to ask the organizers, are we running out of time? Is there?
Yeah, please.
Yeah, absolutely. So why don't we open it up for questions? And do you have a mic? You want this one?
Please identify your name and organization.
You want a mic? I was asking for one. That was asking. Go for it.
Hi, my name is Vikram Singh. We are a startup in geospatial and actually social enterprise for geospatial technology. I think a lot of the things that you mentioned, Neeraj, Vinita, right? At the end of the day, it is being able to solve for issues, but even it's a very, very data-driven approach, because how are we going to find these people who really, really need the healthcare, right? Rosita's session was of specific interest to me because at the end of the day, there is only so many resources and so many people to cater, right? So your specific question on, well, how do you make this an economically sustainable model for a player who's, we spoke a lot about AI, but something in the geospatial space and something with all of this data that, Asha Initiative has, is there a model where, we can get these things together and make a social enterprise actually, something which is economically sustainable?
I mean, you're asking for all the answers, man. This is a tough ride, let me tell you, as a
Sorry
startup.
to put you on the spot if I am
no,
not the intention.
I wish I had all those answers, but I'll tell you some of the models that we've seen which have been successful. Firstly, you need a lot of grit. Secondly, you need lots of good friends who are willing to keep giving you money every month for the next few years. So, find a list of those. But eventually, what you need to think about is that, and what's happening in this space of impact, is there is grant money which is available, which you should try and access for the development phase. But while you're doing that, also think about, how am I going to cost this particular service, whatever you're doing? Who's going to pay for it? Is it the government? Is it the private sector? Which part of it? And eventually impact. Let me tell you, all this flows down from impact. So if you are in your decks, if you are not talking about the impact that you may have, it's going to be tough. I'm not sure if I've been helpful, but, that's the little bit of gyan.
I'll just add, you can burn cash only up to a point. Right?
Exactly. So that's
after
why
you
Vinita's
burn, so I'm going to
perspective will be
come
interesting.
straight to your point. So you can burn cash only up to a point, right? Maybe 1, 2, 3 years, whatever your pitches are. After that, whenever I get into a model, I'm asked, why are you saying that the patient should pay 1 rupee? What will it give us? Yes, it will give us something. And that is the attitudinal change. Right? Once you change the behavior of the community you work with towards seeking health, they'll be happy to pay. But then your product should be right up there.
And if you're doing geospatial mapping, one area of great interest is to start predicting hotspots of diseases. If you're able to start putting those maps together, we should talk.
That is exactly what we're doing, actually.
The vector bone, everybody's looking at
Connect
it.
after this.
Dengue, chikungunya, malaria, so absolutely. Okay, yeah, there's one question back there, I think.
I'll just get the mic. Thank you so much for this discussion. My name is Kamna Jain. I work with Future Skills Prime, which is NASSCOM's initiative on a learning platform on emerging technologies. And I'm very happy that, Apollo Hospitals has actually used it for its workforce. My question is that even though this is a platform which provides digital fluency to workforce across verticals, what is it that we can nudge the workforce actually to be motivated to take up these courses? Because even though they are being provided, there is some resistance in the workforce to actually take up these courses and become digitally fluent. How can we nudge them to take up these courses and develop themselves?
So I can tell you, we've had a good take up. The only thing is, of course, issues of time. But your courses are still simpler. I don't know how really to handle AI and clinicians and the large language models, which are very authoritative. So I think the first thing is to ensure that when you put up these courses, they're not pitted against the workforce. That is very important. So you have to rightly tell the workforce they're going to supplement your skills. They're not going to take away your jobs. These are going to prepare you for the next generation AI. I mean, that's all in this short time I can tell you. Trust.
We had a very interesting trial of a solution called Cure.ai. They were doing AI-based screening of for tuberculosis in X-rays, and none of the clinicians wanted it and I'm talking about across Nagpur. And we had to actually go back and we had to redefine our study to say it is not diagnostic, it's screening and triaging. So actually, you're just getting a decision support mechanism. So, unless they're convinced that they need this for improvement, they will always push it. My children don't want to learn PowerPoint, so I can't convince them. Yeah.
They have
To just
Canva now.
answer your question, it's so important for us to build that trust between machine learning and the workforce.
Right. Thank you so much.